Hi, my name is Todd Thompson, and I am the team leader of Mental Health Intensive Case Management Program here at the Tucson VA. And I want to talk to you about the early intervention and treatment of psychotic disorders within the VA system. This is something I'm very passionate about. I find that we need to do more prevention and early treatment and break that revolving door caused by ineffective or untimely interventions. Just a quick review of psychotic disorders, primarily what I call the big three: schizophrenia, schizoaffective, and delusional disorders. They have a collection of positive symptoms, negative symptoms, and cognitive symptoms that generally start between 15 and 25 years of age and is considered a chronic, lifelong condition and impact just about every aspect of somebody's life. Key aspects that I think are important to talk about is that approximately about 100,000 adolescents or young adults in the United States first experience psychotic disorders each year. And this actually corresponds to when people join the military. So in the military, they actually see people who have first episode psychotic disorders. Most of the clinical and psychosocial deterioration occurs within the first 2 to 5 years after psychosis onset. It has a very high relapse rate within the first 5 years, and 2/3 of the completed suicides in schizophrenia occur within 6 years of diagnosis. Also, psychotic disorders derail the occupational, interpersonal, and social functioning of an individual and initiate a trajectory of accumulating disability that continues throughout their entire life. Nationally, this is a very expensive condition to deal with. It costs about $63 billion a year in healthcare costs, which works out to about 26 to 31,000 per year per patient, and accounts for about 25% of the United States mental health care cost. And this actually doesn't include increased medical problems associated with schizophrenia. They have higher rates of smoking, obesity, cancer, COPD, shorter life expectancy. So you're actually talking a much bigger number. In the Veterans Administration, it is actually a very costly condition. 4% of actively treated veterans at the VA nationwide have a diagnosis of psychotic disorders. And patients with psychotic disorders actually occupy more inpatient beds than any other diagnosis, either medical or psychiatric. From a nursing diagnosis perspective, you can kind of highlight the comprehensive needs associated with psychotic disorders, and it shows kind of the global aspect of the problem. Just about any problem will be part of a psychotic disorder in some aspect of their care. So, since psychotic disorders start at a predictable time in a person's life, they have a predictable course and are very chronic and debilitating, why do we not start as early as possible in the treating of these conditions? Meta-analysis of early intervention programs show reduced suicide rate, fewer number of hospitalizations, shorter duration of hospitalizations, and longer employment periods. Two examples in the community of evidence-based practice would be the Recovery After Initial Schizophrenia episode, which is RAISE, which was sponsored by the National Institute of Mental Health and involved about 400 patients at 34 clinics across the United States, fit that 15 to 35-year-old range, and treatment lasted about 2 years, and it had a comprehensive and multidisciplinary treatment program organized into cohorts. And what I mean by that is they recruited a group at a particular site, and then they all started together, and they provided individual medication management, family education, individual resiliency training, and supportive employment and education. And they demonstrated that clients stayed in treatment longer, experienced greater improvement in their symptoms, interpersonal relationships, and quality of life, and were more involved in work, school, compared to clients at typical care sites. In the United Kingdom, Canada, and other European countries with nationalized healthcare, they have what's called coordinated specialty care, which is a comprehensive multidisciplinary early treatment program guided by a case manager um, that combines assertive case management, individual and group psychotherapy, supportive employment, education services, family education support, and individualized medication management support. And studies have consistently shown a decrease in symptoms, improved outcomes, and increased quality of life. An important thing about the coordinated specialty care is that they demonstrated that it doesn't cost more than standard care. The intensive services up front cost, but it results in a decreased hospital emergency room care over time. So if we were going to take an inventory of what there is at the VA to treat early intervention, we would find that we're pretty good off. The VA is considered one of the largest and most robust healthcare systems in the United States, and it has very comprehensive mental health services, including ambulatory, inpatient, 24/7 care, specialized substance abuse, rehabilitation recovery programs, and specialized treatment programs for seriously mentally ill, as well as other programs that deal with housing, homelessness, financial problems, things of that sort. This aligns very well with the Social Determinants and Healthy People 2020. We have a lot of resources to meet daily needs, access to educational, economic, and job opportunities, as well as excellent access to healthcare services through what's basically socialized medicine in a very, very large and robust program. It's also important to note that veterans are eligible for all local, state, and federal programs on top of the VA services. So it's not uncommon for someone to be getting VA care and Medicare or Medicaid or some other private insurance. If we look at the current mental health treatment process, what you see is that it requires very good organizational and cognitive skills to negotiate the system. Veterans have to start by getting enrolled in the VA, and then they are assigned to a primary care clinic who would then refer them to the mental health clinic if they feel like they meet criteria. And then after being seen at the mental health clinic and determining that they cannot function well within normal outpatient mental health, they can be referred to specialized mental health programs. And if there's any type of individual or system failure in this process, the patient may result in hospitalization or become completely disengaged from treatments. So you can see that this is not a system that's easy for people with significant cognitive or symptoms that would interfere with their ability to negotiate the system. So if we were going to look at trying to adapt kind of an off-the-shelf program at the VA, we would want to look at the components of assertive case management, individual and group psychotherapy, supportive employment, education services, specialized medication management, and family caregiver support and education. And then we'd want to offer these interventions early in the disease process before disability occurs. Fortunately, we have all of the pieces of the puzzle as part of the VA program. We have very good outpatient mental health clinics with psychiatry, individual and group therapy, and some psychiatrists specialize in certain things such as PTSD or psychotic disorders. So we could actually find a psychiatrist that would focus on this population. We have very good inpatient treatment. We have primary care and mental health integration. At the Tucson VA, we call that the Agave Clinic, which works with the psychiatrist. We have a mental health intensive case management that operates within the community and is a collection of nurses and social workers that do home visits. We have a psychiatric rehab and rehabilitation program, as well as very good supportive employment, compensated work therapy, vocational rehab. And then on top of that, we have caregiver support programs, other case management for people that were in Iraq and Afghanistan, and as well as many, many other supportive programs and fee-based services as needed. But the system is that they get these intervention only after serious psychiatric symptoms or impairment occur. So what we would want to do is to develop an early intervention process where when a veteran presents at enrollment, we identify them as needing early intervention services through being recently diagnosed with psychotic disorders, and they would be immediately assigned to an early intervention case manager who would then help guide the patient through getting into the appropriate services, primary care, outpatient mental health, and specialized mental health programs. And the veterans would not need to meet further criteria for identified interventions that are part of the early intervention program. So in other words, what we're not going to do is to develop a ground up program. We're just going to utilize the programs that we have and work on changing the criteria. This focus is actually a very good kind of focus on individualized care. If we look at like a Maslow's hierarchy of needs, every veteran coming into the VA system may be at a different level with psychological, psychosocial, physical needs, and may come with completely different sets of resources. And so we can look for the right intervention at the right time through the utilization of that intensive case manager. This is very much aligned with Healthy People 2020 mental health goals, reducing the suicide rate, increasing the proportion of seriously mentally ill people that are employed, and increasing the proportion of seriously mentally ill people that are in treatment. From a cost perspective, this is a very efficient approach because since we're dealing with low treatment numbers, newly diagnosed psychotic disorders make up a very small percentage of enrolling veterans at the clinic. At Tucson, we have calculated that to be about 5 to 10 a year based on kind of an informal survey. No new programs must be developed. We're going to be using all programs that are already there. And these programs are actually basically underused. They're not operating at full capacity. And so what we can do is just plug people into them. And then as the program expands, we may hire new staff if it's cost effective. We can determine it's cost effective through an evaluation program. We have a very good electronic health records in the VA system where we can actually search up to 8 million patient records. And this would allow us to evaluate enrolled veterans who are receiving this intervention and compare them to veterans across the country that are not receiving this intervention. And we can look at everything from suicide rates to no-show rates, hospitalization rates, and then on top of that, we can do standardized questionnaires and different things like that. Ethically, we need to make sure that we're watching out for autonomy and self-determination. Case managers can interfere with an individual's right to choose, and that's through the persuasion of a case manager and the case manager deciding what's best for them versus what's best for the patient. And informed consent can always be a problem with patients with psychotic disorders who may not totally understand the intervention consequences or situation. If we developed a logic model, I don't really have time to go through this, but you can kind of see just a good way to kind of lay out all of the activities, imports, research, outputs, and outcomes, and then data sources. So this, if we were going to flesh out this program, we'd have to greatly expand this logic model. So in summary, psychotic disorders, start at a predictable time. They have predictable outcomes, and that research has shown that if we develop an early intervention treatment programs, we can help prevent full onset of symptoms and improve long-term outcomes. And due to the low robust nature of the VA, we have off-the-shelf capabilities that can provide these services. And all we really need to do is work on changing the criteria of existing programs and utilizing specialized case managers. So I've given my references that I've used in the process, and you can look those over if you need to. And I appreciate your time. Thank you.